All right, good afternoon, everyone, and welcome to today's very exciting and I think very important discussion on the overall impact of diversity, equity, and inclusion on the donation process and the subsequent donation outcomes. Today, we will explore the impact that biases of healthcare professionals, whether conscious or unconscious, can have on families of color. Furthermore, we'll discuss the impact that those biases can have on the OPO's ability to effectively support potential donor families as they engage in donation discussions. Now, following the didactic portion of today's session, we will transition into our collaborative breakout discussions where you'll all have the opportunity to connect with one another and apply some of the lessons learned to identify strategies for you and your colleagues to implement in your everyday practices. Our first breakout discussion will focus primarily on hospital partnerships and how to effectively engage and huddle with your hospital partners. The following breakout discussion will focus on biases and how to combat biases in your field and maybe even in your everyday life. Once we've concluded both breakout discussions, we'll return back to our main session, where we'll collectively share some of the insights and key takeaways that were captured in your respective breakouts. Now, to help us ensure that this is a successful and engaging experience, I'd like to ask that you all take note of some of our recommended rules of engagement for this program. As you can see, this is not our typical webinar platform, so to ensure that you have the best view of today's discussion, we recommend adjusting your view so that you can see the active speaker window only. To do so, please navigate to the upper right-hand corner of your screen and set your view options to speaker view. Now, upon joining us for today's discussion, you may have also noticed that your audio lines have been muted. This is to help us ensure that we have the best audio quality for our presenters and of course our moderator. So please remember to keep yourself muted at all times unless you're actively speaking during our open discussion periods. Now to that point, please be sure to also turn on your camera. We'll want to see you during those discussions. Now, of course, you're welcome to turn them off during the presentation itself, but once we transition to our open discussion periods, we'd appreciate it if you turn on your cameras to fully engage with our presenters and your colleagues. Another thing that will be super helpful for our moderator of today's discussion is to update your name in Zoom so that we can recognize you. So to do that, you'll go ahead and open up the Participants tab, click beside your name, and under More, you should see an option entitled Rename. We recommend typing in your full name and possibly even your organization, as you see here in the example on this slide. Lastly, this is meant to be an interactive and engaging learning opportunity, so please take advantage of the chat feature. If you have any questions for our presenters, please feel free to submit them at any time using the chat box. Likewise, should you want to add to the conversation and share your thoughts, you're welcome to submit your comments at any time. For those of you who may have submitted questions during the registration process, please know that we've done our best to compile your questions and we'll have our presenters address them throughout the course of today's discussion. Once we've concluded the formal presentation and before we transition into our breakouts, we'll transition to our Q&A discussion where our presenters will address as many of your questions as time allows. Now, for those of you who may be interested in continuing education credits, please note that we are offering 1 SEPSI credit and 1 nursing contact hour for your participation in today's discussion. Following the conclusion of the program, you will receive an email from us with detailed instructions on how to claim your credits. Having said that, even if you're not interested in CEs, we highly recommend obtaining a certificate of attendance so that you can complete the post-event evaluation to provide us with your valuable feedback. We certainly want to hear your thoughts on today's discussion and would appreciate your input on future programs or topics that you'd like us to consider. At this point in time, I'd like to go ahead and begin today's discussion by giving a warm welcome to our moderator, Ingrid Palacios, the Multicultural Community Outreach Program Manager at New England Donor Services and valued member of the Alliance's DEI work group. Ingrid, I cannot thank you enough for being with us today. And at this point, I'll go ahead and turn the floor over to you.
Thank you, Deanna, for that warm introduction. Good afternoon, everyone. It is my honor and my pleasure to be here representing New England Donor Services, but also as a member of this amazing work group from the Alliance, the Diversity, Equity, and Inclusion, and having been part of this conversation series that are so relevant and these discussions for all of us, professionals, not only professionals of color, but all professionals in the OPO and in the transplant world. So it is my pleasure today to be introducing my colleague and amazing friend, Stephen Averhart, Family Services Manager at New England Donor Services, who's gonna be accompanied by an amazing expert and subject expert matter, Demia Kandi, founding partner of a chief consultant of the Significance LLC. Demia Kandi is the founding partner of Significance LLC, a consulting firm specializing in training, strategy, and program design, a global leader with an innate ability to guide and influence others. Demia is a change agent with a niche for identifying best practices and a content expert in the area of diversity, equity, and inclusion within 15 years of strategy, outreach, and community relations in the organ procurement organization field. Her specialization in diversity, equity, and inclusion, DEI, and OPO multicultural outreach are crucial in building cultures of inclusion within an organization and the communities they serve. A native of Columbus, Ohio, Demia earned her bachelor's degree in psychology from the Ohio State University with a master's in family studies. She's a passionate facilitator and motivational speaker, not just in the business of professional development, but people development. According to Demia, success is subjective. Being significant requires having an impact and changing lives forever. It is her goal to help companies reach beyond success to significance. So I don't want to take more time because this topic today, this presentation is full of amazing information, and I only feel blessed to be part and be joined by these amazing speakers that we're going to be introducing. We're going to start with my amazing colleague, Stephen Averhart, who both of them are going to be talking to us about the impact of diversity, equity, and inclusion in donation outcomes, how biases play a role, how to overcome our own biases, how we need to know and learn about it so we can serve communities of color in a better way. So without further ado, Stephen, please take it away.
Thank you very much, Ingrid. I appreciate that warm introduction. I'm not sure that I'm deserving. I'm sure Demia is, but we greatly appreciate it. And thank you all for joining. So you saw the title, The Impact of Diversity, Equity, and Inclusion on Organ Donation Outcomes. But in addition to that, if I can manipulate this slide. Thank you. Implicit bias in healthcare. How authorization and donation can be negatively influenced. Here's what we know. We know that as OPO professionals, one of the most important tasks we have is interacting with grieving families in hopes of painting a picture of transcendence, walking with these families, holding their hands, supporting them while trying to change the ending of their loved one's story. Now, this is not easy by any stretch of the imagination, and we, for the most part, only have one chance to get it right. One chance. There are a multitude of things that are out of our control. At the same time, when it comes to requesters and our interaction with next of kin, there is no certainty when it comes to which gifts will be suitable for donation. There is no guarantee that the patient will remain stable throughout the donation process. We can't guarantee how many lives will be saved and enhanced, if any at all. But what we can guarantee, what we can control, and what we should be trying to guarantee is that each and every family is treated with the same level of respect and patience. So how do we do that? When you think about it, the reality is that this is very difficult to achieve. There are many interactions that these families experience prior to the OPO having a sit down with them. Thus, we are heavily reliant on the care team at hospitals, including clinicians, providers, and so on, to set the table for the OPO to have a meaningful interaction with these families. So, biased examples. There are a litany of these. I have just captured a few here, and they are highlighted in red, the ones that I have personally experienced or witnessed. Some of these biases help to shape the family's experience in the hospital well before a donation conversation is had. If a family, in particular a grieving family, feels slighted or unheard, that can directly impact the donation discussion. Implicit bias by definition, the subconscious bias that refers to attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. Aside from the universal OPO needs of the hospitals throughout our country, which include, we all know it in the OPO world, not preemptively mentioning organ donation, calling in timely referrals, maintaining the option of donation by supporting the patient, we also need fairness, cultural humility, and an ever-present desire to ensure that all families are treated the same, and understanding that every family is unique. No family is the same. We should be guided by what a gentleman by the name of Jim Boggs taught me many years ago, which is a moral compass. This moral compass should constantly guide and remind us that we don't know what we don't know. And what we do know, we may not be correct. In a nutshell, it is plausible that we have been told or taught things that may not be true. So our perception of something or someone may not be accurate. Go to the next slide. Deanna, would you be able to manipulate my slides? I'm having some issues. Thank you. So we have several biases. One is, racial bias, but before going into that, I'd like to go into implicit bias. And part of that is racial bias, right? So as you can see, people of color are sicker and die earlier than other racial groups. And this is an uncomfortable reality. The reality is that people of color do not have and have not received the same level of care as other races. It's not a stretch to believe that the families we have met with have had their own personal experience with healthcare that have left them feeling empty, distrustful, well before they have arrived to a hospital because their loved one has experienced a devastating injury with a poor prognosis that will ultimately end in death. It's also no secret that people of color are sicker and have shorter lifespans. And this can be directly tied to the receipt of lower quality healthcare. They have experienced their provider giving ineffective treatments, in a sense, to them or their loved one. In fact, the National Academy of Medicine had a study, which is a bit dated, I believe it was from 2005, found that even when income, insurance status, age, and severity of conditions are comparable, people of color still receive lower quality healthcare. And lower quality healthcare has defined and has been defined, as being less likely to be given appropriate cardiac care, receive kidney dialysis or transplants, and to receive the best treatments for strokes, cancer, or AIDS, resulting in people of color in the United States being more likely to die from cancer, heart disease, and diabetes, simply due to their race and ethnicity. Not just because they lack access to healthcare, which is an important note. There was another study of over 400 hospitals that indicated that Black patients received older, cheaper, and more conservative therapies than Caucasians. Why is this important? It's important and relevant because the narrative is already out there that the lives of people of color are not weighed the same. If families of color already feel this way, if you combine that with this same family being on the cusp of losing a loved one who they care about dearly, if they feel unheard or have an inkling that less than stellar care or treatment is being provided to their loved one, then we have a problem. My point simply is that it is imperative that hospitals have effective communication with families at all times. If this does not occur, we run the risk of having families that mistrust the hospital. And if they have no trust in the hospital, this can obviously directly impact the donation discussion and ultimately authorization. Next slide, please. Bit of a delay. So another bias is language bias, right? This creates miscommunication between the medical providers, whether it be doctors, RNs, social workers, and the family. And I can sum this up in 2 words. It's a problem. There have been, in my personal experience, several instances where there have been or has been a family at a hospital in which English was not their primary language. Even though some extended family members were present that spoke English and understood, legal next of kin did not speak English. And so the care team relied on extended family members to translate what was being said. In my estimation and in my experience, this is no good. There needs to be a trained interpreter present for all end-of-life or goal of care discussions, and that does not always happen. Now, I must say, in fairness, I have also witnessed families decline an interpreter. But what I've suggested to the care teams is that I strongly believe that they should get an interpreter if one is available. Why? Those participants on this webinar in the OPO world can attest that there are instances where the care team says to us, okay, you're up. The family is accepting, they want to withdraw, or they know that their loved one has passed. We go ahead and obtain an interpreter, go in to offer donation, and realize that the family is not there yet. They are still hoping for a miracle. In order to have an accurate assessment of where the family is at with their grieving process with regard to their understanding, we need to utilize interpreters at all times, whenever possible. Having an interpreter and ensuring that the family has a clear understanding of what is going on helps to alleviate that chance of miscommunication and indicates to the family that they are important, their language is important, their culture is important. Now, it doesn't end there, because there are also examples similar to the description I just gave, where a family does speak English primarily, but they, for whatever reason, we've all seen it, have a difficult time understanding and accepting a poor prognosis or declaration of death. There's no interpreter for that. What is needed at that time is patience and cultural humility, as I mentioned earlier. A large part of that is understanding that every family is unique, and thus they all have a different, in most instances, level of understanding. Next slide, please. Thank you. When it comes to low income and lack of insurance bias, these are the facts. There is a recognition by most healthcare clinicians that a sociocultural difference between low-income families and the affluent physicians that are caring for them or their loved one may have a negative impact on communication, especially when it comes to brain death and or end-of-life discussions. Just because people of color, in particular African Americans, disproportionately suffer from poverty does not mean that the quality of care and the treatment received by the family should be any different than others. Yes, I would agree that the Emergency Treatment and Labor Act ensures that a patient who lacks insurance must receive required treatment. And in no way, shape, or form am I insinuating that the sort of life-saving measures needed to save a life are measured on whether a patient has insurance or not. But what I am saying is that I have heard with my own ears family ask, you know, is it because he or she doesn't have insurance that you all are not going to be able to save him or her? So there is still a stigma that permeates throughout communities, in particular communities of color, that if uninsured and going to the hospital, you may not come out alive. We in the healthcare industry know this to be an untruth, but many outside the healthcare industry realm feel that this could be true, making it imperative on all of us to make it clearly known that insurance does not play a factor with this sort of a mission. Certainly, if we are discussing patients who are upright, not on a ventilator, and suffering from comorbidities that need therapies and treatments, yes, lack of insurance does play a role in the quality of care and access. We need to remain cognizant of the fact that this can bleed into those situations where a family has a loved one that's on a ventilator who are not clinically savvy and believe that a lack of insurance and low income plays a role in whether or not their loved one comes home or not. Care teams would be better suited, in my estimation, to be proactive in explaining this to families. Furthermore, it is imperative that families are provided the necessary space to process their loved one's demise and be reminded of the details as many times as possible and in many ways as possible, so that they can trust what is being said to them. This places the OPO in a better position to broach the topic of donation when appropriate. Next slide, please. And then we have grief bias. There is a huge need for equanimity. As stated, every family is unique. We grieve differently. At the same time, we as humans are encapsulated in our own circle of normalcy. Therefore, when we are exposed to something different, it can be uncomfortable, unsettling, even unnerving. It's important for us to place all those you words that I just described into a box and set them aside. We must become comfortable with the uncomfortable. There have been many instances where I've witnessed security being called on a family because they are overtly grieving, screaming, laying on the floor, sprawled out over their loved one in the ICU, etc. In the eyes of some, this is a family that is not aptly grieving. But I ask all of you, who are we to say? We don't know this family, their circumstances, their upbringing, how they were raised, what they were taught, how they were shown to grieve. This is where cultural humility is important, because that humility allows us to separate ourselves from our own beliefs of how grieving should be done and places us in a safe space where sensitivity and tolerance can be upheld. Security should not be called on a family because of how they grieve. Without question, if there is a threat towards staff, security should be beckoned. But when a family has made no threats and security is called just because of a lower level of comfort, and I put that in bunny ears, this is not good for donation. In some instances, the presence of security can escalate the situation. At that point, we run the risk of grief turning into anger, for lack of a better word. And in some instances, this can impact the requester getting to a yes with that particular family. Not saying that this isn't being done, but I would suggest that most hospitals, if they're able, implement some sort of dual training or workshop with the ICU and ED staff, along with security and similar to bereaved relatives, to create best practices for these sort of situations. Next slide, please. So here are just a few ways of how implicit bias plays out in healthcare. And this probably isn't a shock to anyone who has joined us for this webinar. We know that implicit bias takes place in healthcare. These are the facts. Though not directly related to organ donation outcomes, the examples provided on how implicit bias plays out in healthcare has tentacles, right? These tentacles that can immerse themselves in a family's perception and experience. Though some implicit bias can fall under a functional umbrella, if you will, and are associated with even deep-rooted tendencies, the overall consensus for most people is that they are harmful and destructive. Even if one is not completely sold on the concept of implicit bias, as healthcare workers, we must at least fight for the principle of providing optimal care and compassion to each and every family. Next slide, please. So the potential impact on OPO process when it comes to implicit bias are simple, really. I mean, it impacts the ability to effectively interact with families, create stress between the OPO and staff of the medical team, can impact obtaining authorization, and ultimately that leads to less lives saved, which is no good. Next slide, please. There are many ways in which we could try and combat implicit bias in healthcare. Some of these are very simple and non-complex. Organizations such as ours should make a plan to ensure that health equity is prioritized. We can't throw stones and live in a glass house. So organizationally, we must support our own by providing them with trainings and resources, and more importantly, the opportunity to discuss how they feel about bias that they have witnessed or directly encountered themselves while working. We should also, to the best of our ability, make sure that families have the best communication possible. Whenever possible, we should have interpreters or translators involved in our process if English is not the primary language of that family. I also threw in chief equity officers. I think that, this is a role that's becoming more and more popular. Having a person that is tasked with upholding equity throughout an institution is beneficial, not only for that entity, but the entities that that company, hospital, whatever, interacts with. And last, I think we need to practice what we preach. That we are holding ourselves accountable is very important, no matter the role, to ensure that we are making valid attempts to be as diverse as possible. If that means hiring up diversity, great. If that means, implementing programs at high schools to try and get more minorities to get in the healthcare field, that works as well. But we need to put our heads together to come up with a remedy to try and offset some of these implicit biases that are impacting every aspect of healthcare. Next slide, please. And, we must continue. We must strive on. There are some positive signs here. I mean, we see that, we've gained some ground when it comes to equity, but there's more work that needs to be done. There will always be work to be done. Nearly 60% of national transplant waiting lists are from multicultural communities. When you combine that with the fact that longer term survival is increased when donors and recipients are closely matched regarding genetic background, of course, it's clear that our work is not done. So I added in here some data with regard to the OPTN. And what it says here, and I'm sure you all can see it, I hope you can see it, is that African Americans have grown as far as donation 25% in the African American community, 38% in the Hispanic community, and nearly 36% in the Asian community when it comes to minority donation and transplantation. At the same time, it should be noted that their African American transplant candidates wait longer than non-Black transplant candidates for kidney, heart, and lung transplants. I put in bold, and this is a very important piece, it should be noted that the SRTR model includes living donations. So if you were to exclude living donors, that data would indicate, to the best of my knowledge, that there's little to no difference in deceased donation wait times between African Americans and non-Black transplant candidates when it comes to kidneys. But overall, there is still a lag there. And so I think we owe it to ourselves. Our organizations need to be held accountable. Hospitals need to be held accountable. Transplant centers need to be held accountable to make sure that we are providing the best service to these families. Prior, during, and after any donation conversation about donation takes place. If we do that, I do believe in my heart that we will continue to see these numbers get better, and we may get to a point one day where we are no longer talking about how the lack of equity has impacted lives of people. Thank you very much. I would like to leave with a quote from the good doctor: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Amen to that. And with that, I'll pass it to our moderator, Ingrid. Thank you.
Amen to that, Stephen. That's an amazing presentation. I wanted to add a couple of comments that I saw in the chat so we can address them real quick in real time. Carol is thankful for you mentioning and adding in your presentation weight as a bias. This is something that nobody talks about it, so she's grateful that you add in that, and also for using the term interpreter, the correct term, interpreter versus translator. Because when you do speaking interpretation, is called an interpreter, and she's very thankful to us, to New England Donor Services, for setting up the example of setting up trainings for interpreters that are annual. And she's very thankful for that. So I just wanted to bring that to your attention. This really resonated with her. I wanted to add also my 2 cents. When you talk about the lack of insurance as a bias, I wanted to also mention the legal status as a bias, because that is something that goes hand to hand, hand on hand, as that expression goes, with the lack of insurance. And so we get, and then for those of you that don't know, I also used to work in the family services department, and I used to be a family services coordinator working in the hospital setting. And this was one of the biases that I heard a lot when working with undocumented families. You know, do you know that they are undocumented? As soon as I walk in the hospital, and I will think inside myself, and I will sometimes ask aloud, how does that matter? Why does that matter? You know, are they gonna receive a different treatment because of that? And that is something that you touch up very well. And I just wanted to kind of add that piece there. And also when you're talking about grief biases, right? And how the impact of culture and language and religion plays such a huge part on that. And for us, Personally, as professionals, we can take that personal responsibility on getting trained and learn about the cultural values of different ethnicities and different races so we can serve them better and we are able to overcome those biases. And finally, on hiring diverse multicultural professionals, need to come from being intentional. Like Stephen said, not only from the hospitals, but also from our own organizations, and not only hiring diverse force, but making them feel included and supported and trained accurately. And so these are amazing points that you touch up, Stephen. And then I want to pass it now to the true expert, Demia Kandi, who's going to talk more about what Stephen and I are addressing and really give us the tools and process all this information on how we as OPO professionals and transplant professionals can navigate and overcome these challenges, because I know the intention is in there. We all, everybody present today here, want to serve our communities of color better. Sometimes we just don't know how. So without further ado, here is Demia Kandi.
Thank you so much, Ingrid. And thank you, Stephen, for laying such a strong foundation. I apologize. I was trying to make sure I was unmuted and was just whipping through on those slides. So I apologize for that. Listen, I just want to take a minute to just breathe for just a half a second. There's a lot going on in the world right now, and it is a lack of sensitivity for us to not acknowledge that. So for anyone who is feeling triggered, as some have disclosed, we honor that. We honor your trauma. We honor your resilience. And we speak blessings, and we must acknowledge our privilege. And so I acknowledge my privilege that though I can attempt to empathize with those in Afghanistan and those who are citizens here now, new Americans, that I'm born and raised Columbus, Ohio. So though I empathize, I will not be arrogant to say that I know your journey, but I honor your pain, and we collectively honor your trauma, and we stand with you, not knowing everything, but knowing enough and being human enough to say we see you and we honor you. Whew. Okay, so let's all just take a deep breath. I'm big on breathing. So let's just, Stephen laid a strong foundation. He gave us a lot of content. And for those of us, some of the content, I don't know about you, but some of it's triggering for me. And so we just want to take a moment and just kind of breathe that in and then exhale all that out. Just exhale that. As my notes fly off my desk, just exhale that. So we're going to talk a little bit about bias in healthcare, just building on what Stephen said. And this is a conversation, so my style will be conversational. So I am just going to dive right in and continue what he started. So he referenced cultural humility. And so I take my definition from Gloria Kersey Matusiak, who has a book on cultural competency that was a part of my study, my certification years ago in cultural competency, especially in healthcare. And so she refers to this sensitivity and understanding towards members of other ethnic groups. And so we try to be sensitive, right? But I think sometimes we struggle with understanding, because understanding requires us to do some work. So, and sometimes we don't want to do the work, right? If we're honest, we just want to sit right in, I believe in the good in everyone, and I treat everyone the same, and I just love everyone. And not just, doesn't it sound so good? We just wrap ourselves in this insulation of thinking that we're good people, and we try to be. But the truth is, if I'm really going to do life with you, if I'm really going to be humble in its truest sense, I have to first acknowledge what I don't know, and then get some understanding. And so learn So you can't just say, well, I don't know. You have to learn. And so learning about other cultures ongoing is going to be so important in cultural humility. And it's also being sensitive, and sensitive isn't just lowering your voice. We have this thing of, I can be nasty if I say it calmly. But sensitivity is really empathy, which is trying to understand in someone else's shoes where they are and meeting them where they are, and not just meeting them, but honoring them. And that's the difference. I feel like we can get there, we can meet, we'll bring in interpreters if need be, and kind of walk through, oh, I'm familiar with this ethnicity and this practice and this religious belief, this religious community, this faith. But familiarity isn't enough. But when you can honor it, even when your understanding is different, that's cultural humility. Not just being sensitive, not just understanding, but also honoring. And so a big part of cultural humility is your self-reflection. So when I'm doing DEI for an organization, especially with leadership, you have to start with, you can't do effective DEI unless it's a top-down approach. But I like to spend a day just on self-reflection. So this whole notion of we've done our training, like there's no such thing as training. It has to be a continuum. It has to be ongoing. It has to be conversational, but it's self-reflection. So it starts with the individual person, regardless of the circumstance, regardless as to what you're walking into, you have to stop. You start with yourself. What are my biases? What am I walking into? What do I need to fix, examine, be conscious of? What are the areas that I don't see so clearly? What are my barriers or blind spots, as some have said? And just being aware of that. I always say, I don't know how great of a person I am, but one thing that I feel like I do really well is I can see my own ugly. And very few people are comfortable seeing their own ugly. And I don't mean physical appearance. I'm not talking about that. I'm not talking about self-deprecation. I'm not talking about that at all. Low self-image, I'm not there. I'm saying I have this ability to think of, in any situation, okay, what could I have done differently? Okay, let me look at me first. Not me first as in me first, but me first as in, okay, where could I have done things differently? It's that introspection and that self-reflection. And it's important. And one of the biggest challenges that I find is when you have leadership that don't practice self-reflection. Because if you can't see your own ugly, you can't lead, and you can't guide, and you can't navigate. So having that moment to see it, like, didn't realize that, and then deal with it. So either make a commitment to be better, because you don't want to sit it. We don't sit in our ugly, right? We don't have time to sit in that, but we do acknowledge it, make a plan to be better, commit, and move forward. Personal critique, acknowledging our own biases, and honoring other cultures. I said that earlier. That is so important. So we have to examine what you bring and honor what they bring. And it's not always the same, right? If we're honest, it's not always the same. So, and we'll talk about the fallacy of appropriate grief and all of that. But if I'm an introvert, for example, and I just, anything loud is just, it throws me off. I can't even understand it, because I have mastered the ability to articulate my thoughts and needs without elevating my voice, without being overly dramatic. And so therefore, I could struggle to see that or even value that in someone else. And so it's being able to say, that's not my way, but I honor it, not just, well, this is how they are, or accepting, but honoring, right? Think about loving relationships. Don't we want to be honored, not just accept? Like I said, we don't, that T word, that tolerance word is a dirty word for me. I tolerate you. Like, tell me when that felt good. You are the love of my life, and I tolerate you. Like what sense does that make? So it's really honoring what someone else brings, even when it's different, right? Because that's where the real work begins, when it's other than even what you can immediately understand. Because we can all grow to understanding if we do the work, but sometimes things are immediate. And so just learning to honor that. Hidden bias in healthcare, you must first discover before you uncover. We are so eager to talk about the challenges that we see externally without addressing those within us internally. So you cannot go out here and uncover all of these biases that you see from everyone else without first discovering your own. That's a DKO. You can write that down. Call those me and Kandi originals. All right. So I want to just kind of go through. So I need to pause. My work is I work with a few OPOs, and I've done outreach for 15 years with Lifeline of Ohio. And one of the things that's just been so incredible is just the spirit of collaboration that the organization has. And so I was able to, but my work is in outreach. And so I was able to sit down with our family services coordinators, and it was really impactful. So the information that I'm going to present now was really based on kind of that impromptu focus group that I had with them. So I want to shout them out before you think I'm a genius. I need to take all of that and give that to them. And so we just kind of walked through, and I said, walk me through from your lens. What would I see in the hospital? What do you see, whether you did it or not? I don't need you to necessarily disclose what part, because I just want to get to the root. What are we hearing? What's out there? Walk me through some of the biases. And they said, loud equals a threat. And so they shared a story about someone who was going out, and when they, got to the hospital, the care team was saying, they had to put her out, they had to call security. She was really loud. And so it was a whole issue, right? And this is not anything that you haven't heard or experienced. But what was so interesting is that the family services person said she had to first do the research. What happened? And she went and she approached the mom, and she said, help me help you. How may I help you? What's your concern? And so we kind of walked through it, and she discovered that the issue was how she was treated prior to, and something that happened. And then when she went to talk to the medical team, they weren't going to allow her, they had kicked her out. So she couldn't say goodbye to her loved one. And the nurse at the time said that she felt threatened. And she said, well, did she threaten you? No, but just the way she was acting and her tone, I took it as a threat. And so you called security. And then now not only can she not say goodbye, but the family was loud. So the entire family was unable to say goodbye. And so she said that she had to work to negotiate. It wasn't even, at that point, it was about meeting the need of the family. So it wasn't even about consent. It became about helping this family, because we just believe that if we can help people, we pour into people, they will give in any aspect of their life, not just as it relates to donation. And so she was able to work something out where the mom was able to say goodbye to the loved one. She was able to come back, and they actually were able to have every family member, they coordinated. They said it took hours, but every family, because we were back to rising cases. And so there were limited people allowed on the floor, and they were able to let every person come up and say goodbye. And it took hours, but that was the commitment of the team to say, this is worth it. And of course that they did offer consent, and were able to move through with the donation process. But what was so powerful about that story was just really just this whole concept of loud equals a threat. And when they investigated, it wasn't even that she threatened them with harm. It was that they found her to be threatening. And so I go back to what Stephen said about, I didn't ask the question, what was her weight? What was her height? All of those things that we don't think are in our subconscious, they are. And so what if that played a part as well? But just this whole notion of loud equals a threat. And we see this with communities of color and the way that they grieve. And so, or you know what? And I say this all the time, with communities of color, you get it both ways. You are going to get loud in joy and in pain. You are going to get loud. If you are at a family cookout, it is going to be loud. It's not going to be quiet. The music's going to be loud. It's going, and so to ask me to somehow alter parts of who I am when it's appropriate, quote unquote, appropriate for you, is just disrespectful, and it doesn't honor who I really am. But when they're, oh, can we tell the truth? When there's an office party and they start playing music, who do they want? Oh, come on, Demia. Come on, we got the music playing. Come on. Oh, now I can be outgoing. Now you want me to be outgoing? So we just have to we have to honor that. You have to look at, it goes both ways. And here's another thing. And so I use this phrase, this is not my phrase, this is the phrase in the DEI culture, this notion of white supremacy. And so we think white supremacy, we think skinheads, KKK, that is extreme. White supremacy is really the belief that white is right, that anything that practices along the line of majority culture or white culture is considered to be right. And so when we look at the grief fallacy, and I'll talk about that a little later, it's rooted in this notion of white supremacy, that if you grieve in a way that is similar to the majority, then that is appropriate. And so as you hear that notion of white supremacy, I need you to, it's a paradigm shift. I need you to shift your brain and how it was taught to you as a child, and understand that it really is this notion that from physical features to lifestyle to neighborhood, that everything about majority culture or everything about white is really colonization that just never ended. And it is not just a Black dynamic. It is actually multi-ethnic and multicultural. So you see that with, if it is a white religion, then it is considered to be more right than a religion that is more adopted by people of color. And so that's just a little something. Grieving family equals nuisance. If you've ever been a family support coordinator and you come in on the scene and they talked about the eye rolling of the care team. There's a family here. And it's just, and this is just, I'm sorry, I'm pretty straight, no chaser. Like I'm pretty like, I'm sorry, we have to get really comfortable with the uncomfortable. So if this is making anyone uncomfortable, I apologize, but I can't pity pat with this. We have to really address real biases because Stephen laid such a strong foundation. But just the whole notion of grieving family as a nuisance. If it's too much, if they're asking too many questions, if it's too long of a process. And that's just another thing that they found. And again, that gets to that fallacy of grief. Black equals bad kidneys or drugs. That's just another thing that is often, if you have a Black patient, they said that they have had care teams that have said to them, well, you likely won't be able to use their kidneys, or well, drugs, surprise. I was really fascinated by what I learned. And I know many of you that are in this line of work, none of this is surprising to you. I thought this one was interesting. FSC is the traffic controller. So this role of, okay, so, and almost like once you're on the scene, all right, you just take over, you got it from here. So you're coordinating with the families and you become this, and when I say traffic controller, I don't mean it in a positive way, even though everything that you do is positive. I mean it in a way of, you now have been ordained the person to navigate all of that. And I'm saying all of that on purpose, exactly the way that I'm saying it. Like this process is just slowing down everything else that we have to do, because I'm getting off in a few hours and I need to make sure that, you got that? Okay, good. And then you become the person who navigates all of that. And I just found that to be really interesting. So before we get to strategies, there were some things that they said in this conversation that I just thought were just really powerful and worth sharing with the collective. And one of the things that they said is that we have to be so careful about what we do, because in death, families can see right through you. And so you have to be transparent and you have to be honest, because there's something about death, there's something about end of life that heightens senses. They may dull some, it may dull some, but it also heightens senses and awareness. They also talked about the idea that stepping into someone's grief is the most vulnerable space that you could ever step into, and it is an honor. They talked about their role as there to listen. This notion of, I think I talk about this later, conversation versus approach. We don't approach families. We have a conversation with the family. And so I just, when they were talking to me, I was hearing these themes and I said, wow, it's just really interesting how it reminds me of the first time I traveled in the pandemic, and when I felt safe enough to travel. It didn't matter what they did in my hotel room. I came in, I don't know about anybody else, I had my Lysol, I had my Clorox wipes, I had everything. I came in and I was just cleaning everything. I know, well, we cleaned it. I know you did. I'm just cleaning everything. Oh my goodness. I think I froze. I'm cleaning. Can you hear me? Am I here? Okay. I'm just cleaning everything. And it didn't matter what had happened before I got there. I knew that I could potentially control outcomes, and I had a responsibility to my own health. And so I said, you remind me of that. Family service coordinators it doesn't matter how that family was treated before you got there. You go in and you sanitize everything that has happened, and it is work. And you sanitize layers of distrust. You sanitize layers of mistreatment. You sanitize layers of racism before you even get to consent. And so understanding that, and I said, wow, what is your prep? What must you do before going into that environment every day? And so they shared a little bit about, that, and just this has to be something that you really want to do. No. Like I say, it's interesting how people have stumbled into DEI. I think I really want to go into DEI. And I'm like, nobody's in DEI who wanted to do, you get called into that. Like you were doing that in kindergarten on the playground before you knew what it was called. Like you can't do this work just because it's the in thing to do. And I feel that way about what we do. And especially if you're going into the lowest point in someone's life, and everything about you, there has to be a process every time you do it. And it'll be different for each of you. And I am so in awe of every one of you who do it. Whatever it is that you have to peel back, it's like that philosopher that said tabula rasa, that you come into the world clean slate, that you have to come in and wipe the slate clean. And that includes your own stuff. So the fight you had with your neighbor on the way there, or your child, or your significant other, your partner, you have to wipe all of that out and get into a space, even in end of life, to facilitate healing. And that's what you do. And that's powerful. So as we look at these strategies, I'm double clicking. Did I lose my Okay, so clean slate, attend to, and I know that you're taught this in your training, this notion of attend to, that help me help you, what's important to you, what's the main concern for the family, bringing healing to families, really understanding that being whatever that family needs, and doing your own set of investigating. Eliminate the appropriate grief fallacy. There's no appropriate way to grieve. And here's the thing, we've been taught that, right? This isn't new. This isn't revelation knowledge, if you will, except that we all carry our bias every day. Every day. And as much as we work on them, as much as we think that we have tackled it, there's always going to be that one family, that one case where you have to re-engage with your bias and make a decision. And we all make mistakes. And so just continuing to understand the eliminating appropriate grief and the fallacy thereof. A conversation, not approach. I talked about that. Relationship building. Now I could be here, but I'm going to be respectful because I only have a minute left. Determining what's important to the family, knowing your role to heal, and chipping away at the layers of distrust. And this is just really important. We're not only advocates for families, but the cultures they represent. The cultures they represent. I could talk on and on and on, but I want to be mindful and allow some time for us to get into our breakouts. I hope that anything that was good that I said was food for your soul.
Amazing. Everything that you say was food for our souls. Everyone is so engaged, and we have many comments for everyone, just to thanking you for being so real and giving us this message that we need to hear in this way, that we can all feel safe to feel what we feel and to learn what we need to learn. And so I just want to tell the audience that because we went a little bit over the Q&A session, we are hoping we can have Demia and Steven again in a second part of this presentation, because we have so many questions and comments that we would like to address with time. And we don't want to take that time out of the breakout sessions, where we are going to be processing more about this information, and maybe have a little bit of time of address some of these questions that you guys have sent us. I'm going to pass this over to Diana, who's going to guide us into the breakout sessions. Thank you so much, Demia, for being so awesome. And Steven, of course, for setting up that incredible foundation. This is just, he's giving me the chills. It's just so good. So Diana, please, would you take it away for the breakout sessions?
Sure. Thank you so much, Ingrid. And thank you. A huge thanks to Demia and Steven for such fantastic presentations. I think just based on the comments I'm seeing coming in the chat, there's a lot of valuable insights that you all have shared with the community. And I think this is a discussion that we could benefit from continuing maybe at a future point. But in an effort to give you all an opportunity, as we mentioned in the beginning of the program, to collaborate with one another and take some of the lessons learned and applying it to your own everyday practices, I'd like to go ahead and transition our program to our breakout discussions. So for those of you who indicated that you have interest in participating in these discussions, please stay on with us and we'll be sure to get you broken out accordingly. And for those of you who unfortunately have to part ways with us, we thank you for joining us. And for those who requested the PowerPoint presentations, we'll be sure to get those out to all of you following the conclusion of today's program. So having said that, I'd like to go ahead and introduce our breakout discussions. As I mentioned, our first breakout will focus primarily on how to effectively huddle with your hospital partners. So we encourage you all as you break out to discuss effective strategies that come to mind for improving those partnerships, whether it be with the healthcare team or with security or anyone really within the hospital setting. And then our second breakout will focus on biases and how to identify strategies to combat those biases and overcome them. Now, before I actually transition into the breakout itself, I would just like to take this opportunity just to remind you of some of our rules of engagement and also our ground rules as it pertains to these breakouts. I think it's important, I think it's been mentioned a few times that practicing cultural humility and compassion is extremely important when having these discussions. So I'd just like to reiterate some of the things that we've shared in previous programs. You know, we certainly want to hear from each and every one of you, and we want to make sure that you all have an opportunity to participate in the discussions and share your thoughts. But I think it's important for us to remember that this dialogue is really intended to be a learning opportunity. So having said that, don't, of course, be afraid to ask questions or anything like that, but please recognize that this is a safe space for everyone. We don't want to have this as a debate. We don't want to diminish anyone's thoughts or perspectives. We value everyone's input, and we want you all to feel comfortable and empowered to share your perspectives without judgment. So just keeping in mind some of these ground rules. And then with that, I'll go ahead and make the transition to our breakout discussions. So at this point, I'll turn it back to Stephen to introduce our first conversation.
Real quick, I wanted to add for people to know these breakout sessions are not going to be recorded. So we want to provide this safe environment for everyone to make your comments and your questions and share your experiences. Take it away, Stephen.
Sure. Thank you. And thanks for that, Deanna and Demia. Excellent presentation. I really enjoy hearing you speak. So how can we effectively huddle with hospital partners? Discussing effective strategies for improving OPO and hospital partnerships. This includes the healthcare team and security. You know, what I would like to know, and I guess we can, submit questions, or maybe you may be able to be unmuted, is what is the best process that you all have at your organizations when it comes to huddling? Certainly, here at NEDS, our goal is when we come on site, we huddle, and that huddle includes, family dynamics, who is legal next of kin, who's the decision maker, because as we all know, the decision maker is not always legal next of kin. What is their understanding of the diagnosis that has been shared, or if their loved one has been declared brain dead, what is their level of acceptance when it comes to that? What religion do they practice, if we're able to get that from the social workers? Are their family coming in from out of town? So on and so forth. All of these things help us paint a picture. And then at that point in time, we're trying to really assess when is the best time to have this interaction with the family. Out here in New England, certainly if the care team wants to be a part of those interactions with families, we champion it. But oftentimes they don't ask. And then sometimes we're looked at as though we are being secretive with our interactions with the families, when we have nothing to hide at all. The conversation is as transparent as it could possibly be. And the team, in some instances, feels as though they're being excluded, when that's nowhere near the case. And so what we have begun doing is making sure that when we do that huddle, that we are not inviting that care team to be a part of that discussion, but giving all the signs aside from saying that they are more than welcome to be a part of those conversations. At the same time, I have had instances in which a care team, whether it's the MD, the social worker, or the bedside nurse, come into that interaction when we are offering donation to the family and happen to speak and say something that is not true, not 100% correct, and it kind of makes us take a step back. And so it's really important that when you're huddling with these teams and they do plan on being a part of that interaction, that you ask them to make sure that you are leading that interaction with them. And if the family happens to have a question about the clinical care of their loved one, they certainly can chime in, but we certainly want to be leading that discussion. When there are instances in which families have shown up to the hospital with 30, 40 family members, which we have seen, and the hospital wants to get security involved, it's very important to try and de-escalate that and try and get to the root cause of why they feel security needs to be called. The situation is controlled. The hospital is only going to allow a certain amount of family members onto that unit. The rest will be in the lobby. And unless they are being rowdy and threatening staff, having the presence of security there is a trigger for some families to become irate, to become angry. And then that puts us behind the 8 ball when it comes to our interactions with families and ultimately getting them to a yes when it comes to donation. I'm interested to know what some of the things you all do throughout the country when it comes to that huddling process.
Welcome back, everyone. Hope you've all had some time to have some pretty valuable conversations with your colleagues in the community. At this point, I'd like to go ahead and transition to our next breakout and welcome back our presenter, Demia, to introduce the topic of this session.
Yeah, this is just a continuation before. So some of the bias that we talked about previously, you could pick one or one that you've seen in the hospital. And so you want to identify, you want to look at those bias and then identify some strategies to combat bias in your work and in the field.
All right, welcome back, everyone. I'm so sorry if we had to cut any of your conversations short. We hope you had some valuable time to connect with one another. At this point, I'd like to turn the floor back to Ingrid to help facilitate some of our key takeaways and closing remarks for today's program.
Thank you so much, Deanna. I had the opportunity to join a couple of people during the breakout sessions. I'm so delighted to hear everyone's enthusiasm and gratefulness about how real, and this was kind of the impressions, that this is one of the most real DEI conversations that they had in topics in our field, and they are several takeaways, and they understand, and I want everyone to also understand, as Demia said, this is not meant to be, this is it, like one conversation and one training, and that's why the Alliance DEI work group, who I feel very blessed to be part of, we are going to continue having this series of conversations, not only through this year, but also next year. And we always appreciate the feedback, any topics or anything that you guys would like to continue discussing. We would love to have it. I had the opportunity to talk to a very new FSC and requester, and she was very appreciative of learning. And I feel that for every level, like even as seasoned veterans, FSCs or requesters, and everyone that had attended today, I think that we have amazing information that we are going to be able to process and take with us. I'm sure these recordings are going to be available for everyone that register. I know there's been a lot of requests for the PowerPoints. I'll check with Deanna and Glenn if that is something possible, but I'm sure the recordings, which has the PowerPoints, are going to be available. This has been such an enriching session. I know we went over the time, so I don't want to keep anyone. I just want to thank you, and hopefully you can share the information that you learned today and share it with your colleagues, with your friends, with the people that you work with, and you continue attending and participating and supporting this conversation series that we're putting together. So with that,
if I could just chime in just quickly, because I was being asked a question before the breakout session ended. And so Beth from Memphis, please feel free to email me. It's my last name, it's my first name _ last name @neds.org, and I'll respond to you. And thank you all for joining. It's been great, and we had a great audience. And I'm sure that you all had something to take away.
thank you, everyone.
Thank you, everyone. Enjoy the rest of your day.
Bye-bye.